this menu. Let's pick a poison. Right? Spin the wheel. Now, I can give you various and sundry, and I'll tell you at least most of our research over the years, working in Detroit, Adnan and his group have worked on such things as, what's the target? What are we after? Right? In Detroit, we sort of take the approach, what are we going to shoot at the target? What's the bullet? It comes with it. And so we've gone through years of investigation, and I don't know how much time I have to worry about it or not. What is it if we're going to knock blood pressure down? And then suffice to say that, at least along the lines we originally, we hypothesized that it probably made a difference. These drugs have different mechanisms of action. I've described to you all sorts of different possible things that could go wrong with this, here, this, these, that, this part's working, that part. Right? That maybe these mechanisms of action, maybe it actually made a difference. It wasn't just the result of it. And the bottom line, is if you think you want to stop the change, these strong changes in pressure over time, maybe this drug made sense and had a little alpha relaxation, some beta relaxation, maybe it was just purely beta, maybe we're going to go after calcium channel blockers, maybe we're going to do insane things and use nitrates, venodilators, right? ACE inhibitors, which is kind of found to be uncontrollable, or hydralazine. Did I say something about dehydration and vasodilators and exquisite? And we used to give this for the worst reason to the sickest strokes of them all, eclamptics. Do you all see eclamptics? Right? The most fascinating disease known to mankind, short of traumatic brain injury. Well, actually, an eclamptic is really fascinating. We don't know anything, but they are really sick. And we used to give them these vasodilators. And I used to sit there scratching my head because we have ICP monitors in with all this brain edema. And we'd give them the hydralazine and their blood pressure would come down to normal and everybody go, yay! And I'd go like, wow, their intracranial pressure is just skyrocketing. And we killed them all by normalizing their blood pressure with this because this was like the completely wrong mechanism of non-specific vasodilatation in these poor ladies. I like it. The other reason I like eclampsia is it's a disease with a cure. Remove the baby and it will go away. And the question is, can you keep the mother alive long enough to get through the rest of it? Yeah. So, the ideal drug does exist. I want you to know, as I've gone through this. Right? It will lower blood pressure, it keeps ICP down, and it will increase cerebral perfusion pressure in patients who are inadequately long resuscitated. I have personally found it difficult to send patients home on arbitrary infusions. You guys may be doing something differently, but I have trouble.
Now it's hard to even get the drug unless you're executing someone.
Exactly. Well, the Italians aren't very happy with us. I don't want to go through this stuff right now. So, is there something, it's a lot to do with like dropping things. What about making the number bigger? Because Dr. Smith is unhappy. And so some people in different places looked at some patients, and some actually bothered to publish them, and looking at the concept that maybe we could take this ischemic penumbra, and we could save it by pushing harder. Right? And even going back into the 1950s, you can find a few papers here and there that said, well, this patient came in, pretty healthy, got worse. This was associated with the blood pressure dropping. As the blood pressure came up, either by treating fever, giving fluids, or in some cases infusing catecholamines, or recovering, the first report came from recovering from an MI, that the patient got better. Then there were some that said, well, we did this and they bled, or they got MIs, which of course may be a feature in Our Lady here. Right? And we look at, it's been threatened. We've actually been proactive with this, not just reactive. Right? We've said, well, vasospasm, we've got to push harder, so let's push harder. Right? So we have something to look back. And then we also have these concepts of reduced cerebral perfusion pressures after traumatic brain injury, right, where we learned trying to beat the blood pressure up to a mean arterial pressure of 70, the patient's brains got better. Okay, so it kind of hurt their lungs and removed all the benefit. But and then we found in the hypothermia study that 50 was even below that was clearly bad also, right? So you got a nice exact number to work with in the guidelines, right? What's the ideal blood pressure after severe traumatic brain injury? It's about 50, 70. Okay, thank you. We know, that this obviously is issues that are controversial, and we'll say that at least we can find no proven benefit lowering blood pressure in the first hours to days. And we know that we can get cerebral ischemia as they go through. And this concept that we can induce hypertension, or at least augment existing blood pressure, might improve function. Right? And we've got a place we've used this before, and at least we've, I'd say from this summarizing this series, that we seem to have so far an acceptable degree of safety. That's because we're highly selective. Well, this patient looks great, got worse with that, but the heart looks great. Right? We're not giving it to patients who are marginal and we're just starting out. That this may actually work. So, right, the big question, I would look back to Dr. Smith because he doesn't like that number, is what's the trigger? Is it? I gave you an argument why mean arterial pressure is 90. Should it be like the sepsis people? Should we go with the should we go with the brain trauma people and go with this 70? Should we use pure alpha agonists? Well, that probably makes pharmacological sense. Excuse me, in patients who lose sympathetic tone only, such as spinal cord injury, right? If we want to get a little alpha tone in the heart a little bit, it should be hopefully a healthy heart, because we're going to increase myocardial oxygen demand and consumption. Well, actually, if we can't we'll never increase consumption if we can't increase demand. If we can't increase supply, then demand increase. Right? I've given you reasons, maybe not dopamine. Dobutamine might be good if we don't need to do anything to tense up the vessels. Now it's called inamrinone instead of amrinone or milrinone, phosphodiesterase inhibitor. The answer here. Do you need some water? There's did Dr. Smith mess up? She didn't just gotten a baseline transthoracic echocardiogram of poor quality in order to make some decision. Does everybody need? Well, yeah, if you go and look, we do routinely look at cardiac enzymes. Why? Because we know 1 in 5 to 1 in 6 patients will have a degree of myocardial ischemia when they show up with ischemic strokes. And we think on top of that, that if that's 18, that we're sitting in the 1 to 9, 1 to 11 will actually have clinically important cardiac dysfunction. We did this in subarachnoid hemorrhage patients, but not in stroke patients. So if you look at exactly, so even though Dr. Smith didn't tell me what number he wants, so the International Stroke Trial, this is nice for all these small, it's a nice small study of like 10,000 patients. And this is just an observational piece. Bottom line from the International Stroke Trial, give aspirin. We like aspirin. But the other thing is you'll notice there's sort of a sweet spot for blood pressure. And that is if you look at the percent who are dead within 14 days, well, you'll notice that blood pressure too high, baseline, systolic, so we can't fix this. This is baseline before we start messing things up, but at least it's somewhere to consider we're going to mess it up to. That there's this sort of sweet spot in here where somewhere between baseline systolics of 140 to 180, that those who appear to die, the lowest numbers of those who die. And look who's, we sit there and we get all this effort into hypertension. We're so excited because it occurs so often. But who are the real people who are at risk are the ones who get too low for dying. And that's probably because their hearts either don't work, their kidneys don't work, they're sick otherwise, maybe they are infected for some reason, or so on and so forth. Yeah, screw that. So, times forget this stuff. beating a dead horse with this thing already? You're allowed to say yes. These last 3 hours, the idea here is for you all. And so if there's actually questions, you want me to shut up about what, what Dr. Smith and I care about. And we can take it out on you later. But
It's not dead, it's just ischemic.
it's just a skin. There's nothing interesting about
The
that.
horse is in the conundrum.
Yeah.
Nice. Oh, this was that other disease. Here's about this other disease. I don't know, is there anything else that you all want me to sort of beat about this question? Oh, the Takasuba movies. I'm sorry, I didn't bring them up. So this is the other, one of my favorite diseases in the world.
Before we leave this case, maybe I
Yeah,
can
please.
fill in a couple of the blanks.
Please do.
Because I'm familiar with this patient. This patient came in, as stated, basically neurologically normal, with a carotid dissection, but with an occluded distal left M1 and a small infarction on DWI scan, but basically neurologically intact. She had a history of low blood pressure, and she also had ongoing chemotherapy for malignancy. I think it was rectal carcinoma.
Oh, there were a few other little bits and pieces here.
No, it was in there.
It was in there.
So, to fill in the blank, she was admitted to intensive care.
Lots of reasons to be sick.
Standard therapy. She did not get IV TPA.
No, she was.
She was normal. The next day, making rounds, she had dysarthria, and she was weak on the right-hand side. So at that time, she was given IV fluids and started on neosynephrine. And her deficits almost cleared with that therapy, except for difficulty with speech, which was significantly improved. So it's interesting because giving fluids and a pressor actually improved this lady, just like in a patient with cerebral vasospasm. At that time, her systolic target, if I recall correctly, was 120 to 160. That was the target. Now, she had low blood pressure. Giving fluids and neosynephrine, she's able to get her systolic blood pressure up to about 110, 115. Then, after that, her pressure started going down. So then norepinephrine and albumin were added, okay? And still her blood pressure would not go up to 120. That evening, she became hypotensive over a period of time with blood pressures systolic in the 70s. So I think that would qualify for hypotension, and she had a stroke. And now she was incompletely aphasic, but significantly aphasic with right hemiparesis. Then what was done, which is I think where the mistake was made, is that there wasn't an appreciation that she likely had chemotherapy-caused myocardial dysfunction.
You said it was colon cancer, so at least drugs likely to destroy her heart. I mean, adriamycin was probably the most famous, but for colon, she's most likely going to see fluorescils.
I think she did receive 5
But her cardiac function returned to normal, so I don't think she
And
had
that's why,
a chemotherapy.
and that's why my
like
guess is
chemotherapy
this was the problem.
Cardiomyopathy.
Yeah, my guess is that this was transient cardiomyopathy. I don't get any hints whether it was global or segmental.
It was
It was
global.
global hypokinesis.
It was
And so I'm going to say, therefore, I'm right. Oh, let me act like a survey. I'm right. You're wrong.
Well,
But
the issue was,
it's
is
very
that,
well done. You pointed fingers.
but then vasopressin was added. And there was this issue of not being able to evaluate the heart because of the echocardiogram that wasn't done. And then it was, I think, now the patient has had a stroke, it's realized too late that she has myocardial dysfunction, and so now an inotrope is added, and she improves over several days. But I don't believe that when she came in the hospital, she had a cardiac dysfunction because she didn't have a significant stroke. but we exacerbated her inadequate cardiac function by what
Yeah.
we did to her.
Well, so if you look, if you look at the patients who to develop this cardiac dysfunction, either, so that probably the best studied are those with aneurysmal hemorrhage. We certainly see this in patients with diffuse brain trauma, particularly rapid deceleration injuries, so rear end type things where the floor and the anterior fossa and the hypothalamus sit there and snuggle up against each other for a while. And we see it, as I mentioned, in ischemic insular area strokes, which she's pretty darn close. And that's why I'm wondering, because was this global dysfunction? Segmental dysfunction in our work, again, was done with hemorrhagic strokes, was a good predictor that you were in trouble, that you had real ischemia. But it was really rare. Most of the elevations that we saw in enzymes were associated with global dysfunction, global abnormal, or at least precordial changes on EKGs. And then this sort of pathophysiology, which is named for the octopus pot that I was telling you. And this was my guess, based on what you told me, that something like this would happen. The idea here is that it pinches off, the octopus goes in and then can't get out. And so here is where the heart pinches off as well. Here, the left ventricle, and because that's the only part near the base that's squeezing. The rest of this area is just lying sort of floppy in the left ventricle. So very little squeezes forward, and blood pressure drops, and you just get this heart, and we've seen this certainly in aneurysmal hemorrhage patients, where, a heart with an ejection fraction, perfectly healthy, normal 42-year-old woman, and has an ejection fraction of 5%. And this tends not to develop immediately. It tends to develop usually after the first 24 hours, usually within the first 24 to 48 hours. And it will, this is another case of, like I told you, for the most part, these patients will get better if we don't screw up. If we can keep their hearts going, if we can keep their lungs perfused, we can keep their kidneys alive, we can keep their brains alive in the midst of this. And they tend, it mentioned some other things in here, but these, there are no obstructive lesions when a lot of these patients, particularly subarachnoid hemorrhage patients, and particularly in Japan, that's the name of the disease, that there's no associated coronary artery disease. They're otherwise clear, which probably explains why it's global dysfunction. And the only people that were in trouble in our studies, in the annals of internal medicine, were those who had segmental dysfunctions.
So the question is, have you seen this in ischemic stroke?
Yes.
And very small ischemic stroke?
Well,
I mean, which came first, the chicken or the egg?
yeah, I don't know, and that's always, I guess, the question. Or did you? It would be unusual to get global dysfunction if this were the case of, a compromised, say, a compromised left anterior descending artery, and you're now making the heart work harder because there's all this phenylephrine going on and squeezing the vessels and the afterload is so high, the heart's got to push hard and it strips its ability to get supply of substrate. Those tend to be segmental sort of occurrences, not these global dysfunctions. And that's why, it may not have helped, but that's why this was my best guess.
Does the carotid dissection have any role to play in this?
It's a good question. We've certainly seen patients with seatbelt related left carotid bulb dissections or injuries or just complete dissections to the point of just complete occlusion that have had impaired barrow reflexes. But I'm not aware of anybody who's that's been necessarily associated with a loss of cardiac function. And that's just, I don't know. You see a lot of seatbelt injuries like that. And then there's people who go, oh, see, if I weren't wearing a seatbelt, that wouldn't be happening. It's like, yeah, you would be dead. Anyway. And the basic thing is they will get better. I always like this one octopus, calm, happy octopus, leave it in there. Keep these patients alive long enough for them to get better. So, was there any other questions or things I could annoy you with about these? I'll get over other issues, obviously, are the issues of adjunctive hypothermia or not. That's currently under study. Pat Weidman and the ICTIS study are going back for re-review at the NIH. The albumin issue. And I guess the other thing with brain edema is the issue of brought up about hypertonic saline and mannitol.
That question before you leave Takotsubo is unrelated. Do you wait for the Takotsubos to resolve before treating a ruptured cerebral aneurysm, or you just ignore it? What do you do? Do you secure?
Well, generally, so I've been blessed to have trained at and worked at 2 institutions where our motto is, we will secure your aneurysm not later than the morning after admission. So by the time this develops in 24 plus hours, the aneurysm's already secured.
What if you get a patient transferred in from another institution?
Again, this going back to what is a neurointensivist do, I spent a lot of time going to these places and giving lectures and discussing reasons like why not to wait, and so that went away very quickly. I'm trying to we've certainly had those who have had unsecured aneurysms either because we had no intent of securing them. I remember one when I was in training where the plan was a vascular tip. The plan was to do it under cardiac standstill. And this lady showed up like this, and the debate was, well, does anything else need to be done? We're pretty darn close already. Or if we stop her, well, can we possibly start it again? But my denominator's not big enough to.
I just wonder, I've been at an institution.
I don't know why there should be a reason not to, in the angio suite, we certainly, you certainly take patients who are on pressors, who are on, blood pressure lytic agents. I don't know, and cardiologists take dead hearts all the time, right? For left main disease, and we attempt to do something. So I don't see why that should be a contraindication. I'm not sure, please comment, jump in, sir. You're probably not bouncing down doors to take this patient to craniotomy, and you might have trouble getting an anesthesiologist.
I have the same experience as you, though, that the vast majority of the time we've secured the aneurysm, and I can't think of any cases where the patient was hemodynamically unstable from this cardiac akinesia pattern at the period of time that we were looking to secure the aneurysm. Usually it's later.
That's because we do
And the
such a
patients
good
who
job.
show up late, what's that?
That's because we do such a good job of anesthesia for you.
Yeah, that must be it.
The question is if
Are you an anesthesiologist?
Yes.
Good, I'll be getting to you shortly. I don't want to leave any stone unturned.
even in the angiography suite, let's say you're oiling a basilar summit aneurysm, you've got a catheter in the basilar artery, and the patient has a severely compromised cardiac status. Is that, going to potentially lead to increased thrombosis of the basilar artery because you've got poor cardiac output? And there's no way to stimulate it, right?
I've certainly seen a lot of, in the past, Pavern injecting the basilar artery and induced cardiac near or not so near standstill.
That's why I didn't talk about the pavement. That's described. So, one academic institution I was at, we had a protocol that you waited 72 hours. And typically then the heart, we recovered, and then you treat the aneurysm. I just wondered what.
Yeah, it's just been my experience with that way.
And if the patient comes in like a grade 5 subarachnoid hemorrhage, you're not going to do anything unless they get better. So maybe that's the only time they come in that sick. They're grade 5, neurologically, they're moribund, they've got no blood pressure, you're not going to do anything. Otherwise, this seems to happen later.
We're pretty aggressive with port radiation. at least who have been functional beforehand.
Yeah, but you wait for them to get better before you go to the OR. If they've got no
They
blood
go to
pressure.
the angio suite that night. They may never be going to the operating room. A strong push to coil the septuagenarians and so on. That's why there was so much good easy early data, from Joe Esker's on older patients, on poor grade patients, on difficult to approach operative patients, because it's like, oh, let them cut their teeth on this.
Well, grade 4, yes, but grade 5, a true grade 5 is on death's door.
Well, we have a roughly a 1 in 10 functional recovery. And
For grade 5, so
grade 5. And, to me, my personal belief is we throw the whole ball of wax out, for the first 24, 48, 72 hours. If it means, maybe you're going to delay securing the aneurysm, okay. But I've had a whole bunch of grade 5. Well, I've had a whole bunch of grade 5s who, something sometimes gets missed in post-resuscitation, and, they underleaved. Well, he's got a ventriculostomy, and yes, but the hydrocephalus is underleaved. Oops. Yes, you did this, but you didn't get what you were
You
after.
have to actually open it.
Yeah, or
Drain some CSF, yeah.
or put it in the trap ventricle, so on and so forth. So that's certainly one, a lot of grade 5s are clinically grade 5, but I think have other treatable reasons. Certainly we've seen those, they want to hypoperfuse and set them at high, and that's probably, those are the people who clearly, they have segmental wall abnormalities suggesting actual coronary artery ischemia. Those patients don't do well.
But
I
some
think
of
it's
the
a local
grade 5s do
dysfunction.
get better. So the grade 5s that are better by the next morning, they're not
And then there's the
grade
all,
5s anymore, and then we train.
well, then there's the worst one of the missed resuscitations, which are the patients who are grade 5 because they come in stats. They're in non-convulsive stats. And that is, I think, is a miserable thing a reason to miss. So other reasons I'm very aggressive. It's not a grade 5 till I say it's a grade 5 kind of thing. I think, and I think we all feel that way. All of us who are invested in these patients.
Yeah, they're not a true grade 5 until they're still a grade 5 the next day,
Right.
after you try to resuscitate.
Or after when you get the next day, you get there and you find that somebody, whatever reason, missed it outside the hospital.
Yeah, but we don't take them that night to the surgery or the angio suite if they're that sick.
No, probably it's that morning
And
after.
then we see how they look the next day.
But I think part of the issue is grade 5 is a big grab bag. And, you take a patient who's comatose, okay, versus a patient who's comatose who has no Doll's eyes, fixed and dilated pupils, they're still grade 5. But, they're two different things.
Yeah, I love the description. I mean, you use the proper word,
More of
that hung, or bound over to death. But I've just seen too many, wake up with a shot of Valium. I mean, that's just the worst. Or repositioning or opening the ventriculostomy. The ventriculostomy actually works now, or blood pressure's been controlled, or actually we've had arguments with nephrology folks like, well, you shouldn't see this, the BU is only 83, but, please, one run, go down, what's all the fuss about, And, I love that kind of, I love fixable things, and maybe that's the answer to the lecture this morning, was there, it's like making sure we have fixable things, whatever those are.
So back to this,
Yes.
monitoring this patient. It seems that you should treat this almost like a subarachnoid, a vasospasm one.
Well, you're
If
trying to
you do
infuse
Q1
the
hours,
collaterals, you need blood pressure.
You
if
do
you're
Q1
gonna infuse
hours,
through your
and-
collaterals.
and if you pick that up early enough, presumably you can catch it when it's ischemic, not infarcted, and start resuscitation measures early enough.